Hello and welcome to the third session of the 2020 FH Global Summit. It's so wonderful to see new and old friends here. For those of you that are joining us for the first time, this is our 8th annual summit. Our theme this year is driving solutions to prevent inherited cardiovascular disease. And we've been pleased to have several hundred friends and colleagues joining us from around the world each month. My name is Josh Knowles. I'm the Chief Research Advisor for the FH Foundation and an Assistant Professor at Stanford. I'm co-chairing this summit session along with Dan Rader, the FH Foundation's Vice Chair and Chief Scientific Advisor. Dan is the Seymour Gray Professor of Molecular Medicine and the Chair of the Department of Genetics at the Perelman School of Medicine at Penn. Please use the chat feature on the bottom of your screen to introduce yourselves and let everyone know where you're from. I've been seeing a lot of familiar names and new names. Please introduce yourselves. It's important to remember to change the setting to panelists and attendees if you want everyone to see your comments. We will take all questions via the Q&A feature at the bottom of your screen. So please remember to use the Q&A function for any questions for the speakers and panelists. The FH Foundation is so pleased to announce a new publication that came out just a couple of days ago in the Journal of Pediatrics on children with FH and the experience in our Cascade Registry. This is the 10th publication from the Cascade Registry, and this work was led by Sarah DeFerrante and our former chairman of the board, Bill Neal, as well as Sam Gidding and many other important FH specialists from around the country focused on children. These data help us understand the progress that's been made in the treatment and care of children with FH and the work that still needs to be done to underscore the importance of treating and testing for cholesterol abnormalities in youth. If you use the link on the screen, you can download the paper for free until January 5th. We'd like to thank all the principal investigators, study coordinators, and participants for working on this incredibly important paper. I just want to highlight a few things. Diagnosis is still coming much later than expected, especially given the strong family history that's involved for many of these children. Only 39% of the children meet guidelines for treatment, which is under 130 milligrams per deciliter or a 50% reduction in LDL pre-treatment. Children were treated with statins had the greatest level of LDL-C reduction with a 39% reduction in their LDL-C. This is, again, incredibly important. We are pleased to announce the FH Foundation will be hosting a virtual FH Community Forum on December 12th. It will include a panel of individuals impacted by FH who will share their personal experiences of diagnosis and treatment, moderated by Amy Sturm, our good friend. Registration's open to individuals with FH, with high LPA and heart disease, as well as their family members and their healthcare professionals who work with them. Today, we also wanted to thank our corporate advisory board members. These organizations invest in the continued growth and success of the FH Foundation by providing counsel and support to the leadership of the FH Foundation. We appreciate the commitment of these corporate partners who have demonstrated to the FH community and their continued commitment and ensuring that families at the highest risks for atherosclerotic cardiovascular disease have a chance at prevention. And now I'm really pleased to hand this over to Dan Rader.
Thanks very much, Josh. It's great to be with you. And I have to say, I'm so excited about today's event. First, a few comments of introduction. Evidence-based practice guidance for FH screening, diagnosis, and treatment are very clear in guidelines from the AHA, the ACC, the CDC, NHLBI, American Academy of Pediatrics, National Lipid Association, and others. Yet despite all this guidance, today, up to 85% of FH patients remain undiagnosed. These guidelines are clear, and the FH Foundation has assembled a huge national database related to cholesterol management trends. Disturbingly, approximately 20 million Americans within this database who, based on guidelines, should be on lipid-lowering therapy have not been prescribed lipid-lowering medications. In addition, in the publication on longitudinal results from the FH Foundation's Cascade FH Registry published last year, only 48% of FH patients with established heart disease managed to lower their LDL below 100, and only 22% reached an LDL of less than 70. As many of you know, the FH Foundation has been actively working to leverage understanding from implementation science to improve both the identification and the management of patients with FH, and maybe most importantly, motivate behavioral change at the system, the clinician, and the individual level. In that context, we are absolutely thrilled today to have one of the most foremost experts in behavioral economics, Dr. Kevin Volpp, as the keynote for the FH Global Summit. We believe that the insights and interventions from this field of behavioral economics can help overcome some of the inherent systematic biases that impact care for FH. Dr. Volpp is the Founders Presidential Distinguished Professor at the School of Medicine and the Wharton School at the University of Pennsylvania, and the director of the Penn Roybal Center for Health Incentives and Behavioral Economics, or CHIBE, one of two original NIH-funded centers in behavioral economics and health. He is known nationally and internationally for developing the application of behavioral economics to health and for designing and testing initiatives to improve health that have been implemented in tens of millions of Americans. Kevin is also my colleague at Penn, a friend of mine, someone I've interacted with a lot, and I think you will really enjoy what he has to say today. So Kevin, thank you very much for joining us, and I'll turn things over to you.
Great. Well, thanks so much, Dan. Really appreciate the warm welcome and very much appreciate the opportunity from the foundation to give this talk to you today. I want to thank a number of members of our team who have been instrumental in getting this work going. So let me start with some data that you're all familiar with. Heart attacks, of course, unfortunately, are the leading cause of death in the US and many other countries. And we know that a number of medications have been developed that lower the risk of heart attacks by more than half. The question I might ask you then is, what percentage of insured patients hospitalized with a heart attack take the recommended cardiac medications over the course of the following year? I find that when I ask groups this question, I'm always struck by the fact that almost nobody picks 90 to 100%. Many people pick 75 to 89, 60 to 74, and usually it's a smaller subset of people who pick one of the lower numbers. Unfortunately, the data suggest the true number is actually below 45%. And I view this as one of the most sobering statistics in American medicine, that despite the fact we've had all these carefully done clinical trials, substantial evidence of benefit, relatively favorable benefit-risk ratios, yet we don't do very well as a healthcare system writ large. So the question is really, how might we do better? And there's some interesting work that's been done that has estimated that with perfect adherence to cardiovascular medications, the risk of a heart attack could be reduced a lot, maybe as much as 62 to 88%. And there's a recent trial done that actually showed that heart attacks could be reduced in reality by about half if you had 80% adherence. And the challenge, though, to recognize here is that this is not just all about patients taking their medicine. Suboptimal outcomes are a function of both clinician and patient behavior. So for example, when we've looked at our own data within Penn Medicine, we find that only about 50% of patients at elevated atherosclerotic cardiovascular disease risk have been prescribed statins. So I think perfect adherence is almost never accomplished. It's a daunting challenge, but it's a worthwhile aspiration. And that's led us to think about behavior, in essence, as the final common pathway. We have lots of examples within healthcare writ large of technologies that have been developed, but yet where we haven't been able to take that last mile step of figuring out, in this case, how do we consistently get clinicians to make the diagnosis, to appropriately initiate intensify therapy, and for patients to actually take those therapies consistently. The science of medication, the science of motivation has been on an interesting journey. Typically, healthcare providers have used information provision as a major strategy. And information provision is clearly important. In essence, we're assuming people don't know, and that to change behavior, all we need to do is inform people through education. The problem with relying on this is education alone rarely works. There's lots of data suggesting that. And so then the natural inclination over the years has been to think about using standard economics. We're assuming people are rational, expected value maximizers. They'll think like junior economists. And if, for example, we pay doctors to do things, they will do them, and then we don't have to worry about it. Unfortunately, we've also seen that's not really true. And what behavioral economics has contributed is a much deeper understanding of ways in which people have bounded rationality. And that tends to be in very predictable ways. So for example, our decisions are often affected by the immediate future. So immediate gratification looms very large in our decisions, whether we're a patient or a clinician. We often make very different decisions based on how choices are framed, what others around us are doing, about how busy we are. So you can imagine, of course, for clinicians, that's a big issue. But for many patients, that's, of course, an issue too. We don't necessarily have the luxury to sit down and carefully think about every decision. We're trying to quickly move forward and make the best decision we can. And then another very powerful behavioral insight has been around the status quo bias and the use of defaults. Often people will pick what the choice that's labeled as a default is put in front of them. And it's quite striking the degree to which that's true. So for example, organ donor registry lists in Western Europe. If you have an opt-in, 10% of people sign up to be on the list. If you have an opt-out, 90% of people sign up to be on the list. So dramatic differences based on how choices are laid out for people, really highlighting the importance of behavioral economic approaches. So what does behavioral science have to say about the fact we only achieve 45% adherence to cardiovascular medications after a heart attack? I'd break this down into thinking separately about patients once they're feeling better and after the acute symptoms have resolved, and clinicians. So on the patient side, a behavioral scientist might say, we have challenges with a lack of immediate gratification from taking the medicines. I feel well, why do I need to keep taking these medicines indefinitely? In that sense, there also are delayed benefits. It might lower my risk of having a heart attack in the future, but the future is in the future. We know that then because there's potential risks of side effects, or at least perceived side effects, the short-term costs, the hassle, the financial costs may outweigh the benefits in people's minds. And these actions are private. Nobody really knows whether I'm taking these medicines or not. So what might we do? We might think about gamification to provide positive or negative immediate feedback. We could think about creating mechanisms for social accountability with feedback to clinicians or family. We might provide incentives of various kinds, and those could be financial, those could be non-financial. On the clinician side, we might think about a few key factors being status quo bias, as I just alluded to with defaults. So we have inertia is a big factor as long as a patient is stable. There's bandwidth concerns. I, the clinician, have a busy day full of patients. I'm going to focus on what's most salient and what's most pressing. Social incentives. There's a lack of data comparing my performance to others. So while I might care a lot about how I'm doing compared to others, I might actually not know. So we could think then about using defaults and mechanisms to make choices more salient, like active choice of who should be on therapy but isn't, and using social comparisons. So let me share with you some data on how these approaches have been used, and then I'll tell you a little bit about an initiative we've launched as part of the University of Pennsylvania CTSA around ASCVD risk reduction. Here's an example of a study that was led by my colleague Mitesh Patel. It was the first intervention study done in the Framingham cohort. And they came to us and they said, we're interested in going moving to interventions and not just observing what happens with risk factors, but we don't want to use any kind of financial incentives. Can you think of a way to engage people that wouldn't cost anything, but might be effective? So we agreed to do a study looking at increasing physical activity, leveraging the existing family social structure in Framingham. So each family was in essence a team, and we enrolled people with a certain level of status, which they could lose if they did not get engaged in becoming more physically active. Each day, a family member was pinged, and if they had met their step goals the previous day, they would gain points. If they didn't, they would lose points. And in essence, we created a mechanism for gradually increasing status with easily achievable goals where you felt some social pressure not to let others in your family down. So this actually worked quite well. You can see the results here in this graph. We increased the percentage of people who met physical activity goals from about 30% to about 50% during a 12-week pilot intervention. We now have a longer-term version, sorry about that. We now have a longer-term version of that that's being tested out to 15 months in a current NIH study. Another very interesting area, which I think we could do much more with, is the notion of social accountability. I mentioned that medication taking, much like voting, is typically a private act. And there's good evidence that if people realize that their actions are being observed or a mechanism is created for them to be observed, that can be quite effective. This is an interesting example of a study led by my colleague Peter Rees, where he took patients post-transplant, and they were told that adherence reports would be sent to their clinician each month. And you can see here the top line, 88% adherence in the group that had reminders plus notification versus 55% adherence in the control group. The one catch here was that tacrolimus levels were measured and they weren't significantly different. So we don't know why exactly that is. So I would say this is promising, but not conclusive. Another area very useful to think about is value-based insurance design. So in essence, removing financial barriers and using that as a motivation to improve adherence. Good evidence on this from the work of Nitish Chowdhury and many others, that this can improve health without increasing spending. I mentioned on the clinician side, the power of defaults. And here's a very nice example of this. We were asked at Penn Medicine to increase generic prescribing rates. We changed the default from brands to generics. And you can see here what happened overnight. The generic prescribing rate went almost to 100%. A notable exception here was levothyroxine, which was important because clinicians knew the generic formulations had very different levels of bioavailability. So if they had a patient who was stable, they tended to override the default and opt out. That's something we very much like to see in these kind of interventions. The underlying ethos of these interventions is what we would call libertarian paternalism. We're trying to influence decisions. We're trying to nudge people to make better decisions. But if they have strong preferences or reasons to stick with the current path, they should. And this is an important observation because here we see that these effects were sustained for more than 2.5 years. This saved Penn Medicine about $32 million during that time period. Another very important area, social comparisons. Clinicians care a lot about their performance relative to others. This is some very nice group done by a group at USC where they looked at inappropriate prescribing of antibiotics. They found that just giving that information as feedback basically eliminated the use of this inappropriate prescribing. And what we need to do now is really think about using this to encourage a positive behavior as opposed to discouraging a negative behavior. Another important tool to use is what we call active choice. So we have a lot of patients who may be out of sight, out of mind. If we can make it more clear to clinicians, here are the patients who are your patients who are elevated risk but not being treated, that can increase the rate at which those patients get appropriately prescribed. Work led by my colleague Mitesh Patel, the Penn Medicine Nudge Unit, randomized 96 PCPs, nearly 5,000 patients, into 3 groups, either a usual care group, a group which got the list of patients and was given the choice of prescribing, not prescribing, and another group which had that augmented by peer comparisons, roughly raised the rate from 2% to 8%. This was a proof of concept where I think we had a real ceiling effect because it had to be done through a separate dashboard. It's now being tested within the EMR, where I think it has a much better chance to have a much bigger impact. So I mentioned we're doing some testing now as part of our community engagement and research core, as part of our CTSA. And this sits between the Center for Health Incentives and Behavioral Economics and the Innovation Center at Penn Medicine and our Center for Health Behavior Research. We have a platform called Penn Way to Health that's been used to do hundreds of behavioral intervention studies where we're looking at patient behavior in clinical settings and at home, and clinician behavior, and then working on a series of pilot studies which are going to lead to a major RCT. So where we are now with this, we have a 3-year journey to basically design and firm up some of the underlying data to support the RCT, where we're looking at uptake and acceptability in different diverse populations within West Philadelphia, Lancaster County. We have a series of ongoing pilots we're going to do over the next several years, looking at different ways of increasing engagement, and then also testing strategies to sustain engagement, improve adherence and clinical outcomes, with the goal then of launching this RCT of effective ASCVD risk reduction strategies that would be targeted at both patient and clinician behavior. So in terms of some of the different kinds of pilots, this will involve qualitative work with clinicians and patients using contextual inquiry, identifying potential pain points, success factors, piloting gamification strategies, moving this into the realm of medication adherence and use of remote monitoring strategies, test of social accountability, use of centralized versus distributed defaults to change clinician behavior, and then looking critically at how we might best use social comparisons with clinicians to increase appropriate prescribing and control of blood pressure and cholesterol. Here's an example of some of the types of provider and patient interventions we might use. So using enhanced active choice, we might do something like prepended orders in the EHR based on guidelines to address care gaps. We might think about social norming and feedback in various ways, doing this outside of face-to-face visits. On the patient side, we could think about various tools like social supporters, social accountability, gamification, and of course, clinician backup. More recently, we've started working on the critical problem of familial hypercholesterolemia and patients being inadequately diagnosed and treated. As you know, this affects about 1.3 million Americans, causes about 10% of heart attacks in patients under the age of 50, and up to 90% of people are undiagnosed. So a critical gap here is really around late diagnosis and initiation of statins, which, as you know, causes significant morbidity and mortality. As Josh mentioned, statins are approved for kids in around age 8 to 10, but we find that the average age of statin initiation is around 39, the average age of diagnosis around 47. So lots of opportunities to improve if we could more efficiently, more systematically diagnose patients and then initiate treatment, and then of course have patients take those treatments at high rates. We have a new grant proposal that we teamed up with the FH Foundation to submit. Dan Rader and I are the multiple PIs, where in essence we're planning to take a 3-part strategy to tackling this. The first aim is to use a validated machine learning tool to flag individuals at high risk and use all the data in the EHR to diagnose patients and then put those names, patients in front of clinicians, and then in essence use a combination of implementation science and behavioral economic tools to work to make sure that diagnosis is appropriately made. The third part of this then is to increase the uptake of and adherence to evidence-based practice, goal obviously to improve LDL-C and outcomes. I wanted to mention that our nudge unit has created a nudge unit collaborative. We have more than 30 health systems involved, and we're very interested in helping others build capacity. So if anyone is interested in joining that, please feel free to reach out after the presentation, and we'd love to see if there are ways to help you start thinking about some of these strategies within your own health systems. There's a few things I'd love to see FH clinicians and researchers tackle. I came up with a must algorithm here. So measure who should be on CV risk reduction therapy, who isn't. Use machine learning efforts to identify high-risk patients in EMRs. We have lots of data. I think we don't systematically tend to use it. Systematically then investigate ways to optimize clinician behavior, either initiation or intensification of therapy, and then test ways to increase patient adherence to therapies. I think there's a particular resonance with really pushing hard to do what we can to address some of the enormous income-based differences in life expectancy in the United States. These are roughly 10 years in women, 15 years in men, depending where you are on the income distribution. And so a lot of opportunity and a lot of need to think about how can we take some of these approaches, how can we use behavioral science, implementation science to, in particular, improve outcomes among those portions of our population who have relatively poor outcomes now. If you're in the first percentile of income in the US, you have a life expectancy similar to Sudan, Pakistan. If you're in the 99th percentile, it's as good as anywhere in the world. So our goal should be, how do we shift that distribution? How do we move more people to be similar to those who are, have the best life expectancies in this country? So I want to close by thanking the team at our center. Lots of people working on these issues and really doing what they can to bring behavioral science to tackle challenging problems in health and healthcare. So with that, I'll stop and turn it back to Dan. Thank you, everyone, for listening.
Thank you very much, Kevin. It was terrific and really provides a great basis for our next event, which is a roundtable discussion that you'll be participating in, along with three others who I'd like to introduce now. The first is Ralph Muller. Mr. Muller is executive chairman of the Seminole Health Fund in Philadelphia, a national advisor to Manat, and a senior fellow at the Leonard Davis Institute of Penn Medicine and the Wharton School of Business at the University of Pennsylvania. Importantly, Ralph is the recently retired chief executive officer of the University of Pennsylvania Health System, where he served from 2003 to 2019. And previous to that was the president of the University of Chicago hospitals from 85 to 2001. So as you can tell, Ralph has a tremendous high-level experience in running health systems and in thinking hard about how to employ some of the strategies that you've just heard about from Dr. Volpp. Ralph will be joined, in addition to Kevin, by our co-host, Catherine Willimon, the founder and CEO of the FH Foundation, who I think is well known to all of you, as well as to Dr. Mary McGowan, the Chief Medical Officer of the FH Foundation, who shares her time between the foundation and serving as co-director of the lipid clinic at Dartmouth-Hitchcock Heart and Vascular Center. And I know Dr. McGowan's well known to most of you as well. Dr. McGowan's been the principal investigator on over 30 national and international clinical trials and has lectured widely in the United States, Canada, Europe, and Asia on cholesterol metabolism. She was the first chief medical officer for the foundation, and we are very glad to have her back serving in this capacity. So I'd like to now turn to a robust Q&A and discussion. I'd like to remind all the attendees that you can put questions either in the chat or the Q&A, although if you notice, there is a separate Q&A button. And if you can, try to use that for putting in your questions. We'll be monitoring that, and we'll try to address as many of the questions as we see in that. And we'll also be having some robust discussion. So I think next we'll turn to Ralph. And Ralph, I wonder if you would just want to make a few introductory comments from your perspective, having interacted a lot with Kevin and with this concept of nudging and behavioral economics in running the Penn Health system, and any comments you want to make.
Well, thank you, Dan, and Kevin, as usual. It's always a delight to listen to Kevin. I work with him a lot. And as Kevin noted, he's the head of CHIVE. We have many centers at Penn. And part of what we're proud of is that we integrate our research centers right into the health system. We have a very large health system, 7 hospitals, millions of patients, $8 billion of revenue, if you take some simple metrics like that. But we really use the research centers, such as the one that Kevin runs, and one of his colleagues named David Ash runs our innovation center that was started by Kevin about 10 years ago when I worked with Kevin. And we try to use that on a daily basis to integrate what the kind of work that Kevin and all the colleagues you saw on that slide do, and integrate it into what we do. That's an essential aspect. Now, since Mary's on this webinar as well, a lot of us going back 30, 40 years, going to the Dartmouth Atlas, we learned from Dr. Jack Wenberg about the enormous variation of healthcare in America. And one thing at Penn we've tried to do is really reduce that variation and take the kind of practices that Kevin has talked about today and integrate it into the daily care patterns. We have the advantage of having a system that's highly integrated. We are on a common electronic record called Epic. I think a lot of you know that name. We have organized ourselves by what are called service lines, and we have a big service line, which basically refers to populations. We have one called Heart and Vascular that Dan and Kevin and others have worked with, that organizes our patients and our doctors and the nurses and all the other caregivers into common entities. And because by and large, when patients come to a medical center such as Dartmouth or Penn or others, or Stanford, they don't necessarily know, and they'll obviously know what a cardiologist is, but they don't necessarily know all the various specialties. So we try to organize our physicians and our pharmacists and our nurses into one service center to be patient facing. And by doing that, organizing around the patient population, we think we make an enormous difference in their outcomes. And part of what I'm proud of, at Penn, we have the highest levels of patient satisfaction, at the highest level of avoiding mortality, the highest levels in the country among all the 100 big medical centers in the country in terms of bringing down infection rates. So we really focus a lot on how you actually implement the kind of findings that Dan in his career and Kevin in his have come forward with. And we're very proud of the fact we are probably as integrated as any medical center in the country. In fact, Kevin and I play tennis all the time. That's part of our integration. But our major effort is to integrate the findings from science into medical care and make a real difference for the population that we serve. And I think that's an enormous part of the Penn story. So Dan, thank you for making that big board for Penn.
Thank you, Ralph. And we're definitely going to be coming to questions that have to do with how at the level of the health system, we can really make impacts that are durable and important. I would like to pick a few of the questions that are sort of specific to Kevin around his presentation first, and then we're going to broaden things a little bit. So Kevin, one of the questions was in the RCT that you described, what is the endpoint? What is the primary endpoint? And can you say a little bit around kind of the decision and the thinking process around that?
Sure. So the primary endpoint in that trial is change in LDL. We've had some discussion about a joint endpoint of change in LDL, change in blood pressure. We may still go in that direction. We're still about 2.5 years off from actually launching this study. So I think a lot depends on all the preliminary work we're doing in the meantime and trying to determine what makes the most sense based on what we think the interventions we design will have the best impact on.
Great. Another question has to do with the FIND-FH algorithm that we propose to use within the Penn system, and the FH Foundation, which developed it, is also working with other health systems to try to implement. And Eric Seabrands asked, I think, an important question, and that is the generalizability of these machine learning type approaches from one health system to another. I'm expanding on his question, but not only within the US, but then when we think about Europe and other parts of the world. And I guess his question that, Kevin, maybe I'll ask you first, and then Catherine or Mary may want to chime in, is will one size fit all, or is there going to be a need to really customize these machine learning AI approaches to looking at EHR and big data to find FH patients and other types of patients based on the local environment? Kevin, maybe you can start.
Sure. Yeah, no, it's a really interesting and important question. I think it depends to a large degree on whether the kind of data that's available in a given EHR is similar to the data that's available in a different EHR somewhere else in the US or somewhere internationally. Let's imagine one scenario, which is they all have exactly the same data elements. Then, of course, there will be challenges based on differences in clinical practice. So you're going to have different rates of missing data of different kinds of labs based on what the customs are in terms of how often people are seen and what sort of lab work is done. You're also going to have differences in patient populations, which could be substantial. So I would say that I think the work that's done within any given health system is useful as a template, but I think the algorithm in essence needs to be rerun and customized in the setting in which it's going to be used, because you're going to find different things based on all these factors.
Hey, Josh, I wonder if you could comment on that question.
I agree with that. I think that that summed it up quite nicely. That I think these have a lot of potential, but there will be variations in healthcare systems. Of course, the situation with the FH Foundation did in conjunction with you and Michael Shapiro and others, where there's a global look at more data that's sort of universal across the entire country, could eliminate the need for some of that individual running within single cell systems.
Could we just stick to this topic for a second? The concept of mining large EHR data within a health system to find patients who are underdiagnosed and undertreated. Certainly that's true for FH, but it's frankly, unfortunately, true for a lot of other diseases. Ralph, I wonder if you could just, from your sort of health system CEO perspective, speak to the issue of the investment in the EHR, not just as a way to sort of deal with diagnosis and billing and everything, but really this bigger issue of employing big data to improve patient health.
No. Well, thank you, Dan. And as your question suggests, there's been major advances made the last decade in terms of using that data. But let me just note, with Mary on this call and me and Josh, 3 of the medical centers, but there's 100 medical centers like us in the country, and we share data. And in that data, we have shown when patients are treated longitudinally by the same health system, we save about 50%. That's a big one, 50% by having people cared for longitudinally in the same system through a variety of mechanisms that Kevin suggested. When people go to different places for care and move in and out of health systems, in and out of physician groups, in and out of practices, there's bad outcomes for patients and adverse outcomes for society who has to pay for this care. So part of what we have shown, if you really take responsibility for patients over the period of time, and then you do the kind of interventions that you and Kevin have both suggested and committed your professional career to, one can both get better outcomes and better costs. And I've been pushing that. So as you noted, having a common EHR, for example, Penn spans about 200 miles of geography, just like Dartmouth and Stanford do, from Lancaster, PA, for those who know the geography, up to Princeton. But when any patient comes in anywhere in that system, that information is immediately known to everybody else inside the system. Nurses, doctors, pathologists, radiologists, it's known. They can then manage that patient if she or he is seen by somebody else inside the system based on the most current information that they have. The pathways and protocols that Kevin mentioned that have been developed by our physicians and nurses and pharmacists, et cetera, are available there right on the computer in front of the physician or nurse who is managing that care. So that kind of integration of care, which still bedevils America. We have too much variation. Going back to my citation of the Dartmouth Atlas and Dr. Wenberg's inspiring work going back 30 years, is still something we have to crack. But I think we have shown, and I think there's West Coast models like Kaiser and others, Intermountain, if you really integrate care, much better outcomes and much less cost. And I think we have to devote ourselves through the kind of mechanisms that Kevin notes, with good management, teaching, coordination of care that makes an enormous difference. Let me make one last great plug for professionalization of these kind of services. As Kevin noted, as a country, we're not that great about adhering and complying as we should be. And we don't always take our medications. I think we have a professional obligations as doctors, nurses, administrators, all of the above, to really work to give best practice constantly to our patients. Many of you have been trained for 20, 30 years. You know an awful lot. You have to be able to impart that in an ongoing way. And Kevin and I have written about a topic we call automated hovering. I think we have an obligation to professionally hover over our patients. And these days, one of the most important breakthroughs in medicine in the last 10 years is called the smartphone. And that innovation allows us to hover over our patients and constantly remind them through nudges, as Kevin says, and other kind of mechanisms to make sure we constantly remind them how to do the right thing. And I think by doing those kind of things, using machine learning that then advances the kind of nudges that Kevin has talked about, we can go a long way towards better care and much lower cost.
Thanks, Ralph. One thing I hear you saying is that as well-meaning as clinicians are, they're overextended. They're piling additional things onto them and expecting them to make that decision is often very challenging. So the more we can build things in and automate things to do the right thing, the more likely it is to happen. I mean, that's what I hear you saying, and I know.
And the advances in technology make that easier, both for the physician and the nurse or any member of the care team. But just reminding people constantly what the best evidence is and how to take it forth to the population that you're serving.
Yeah,
great.
Dan, can I add to that?
Please.
I think a lot of times the standard response to observed lack of great performance in many healthcare environments is to say, well, let's ask the primary care doctors to handle that. And well, having been a part-time primary care doctor for about 20 years, I can tell you that most primary care doctors feel overwhelmed by all the things they're supposed to do, and then all the things that are crammed into the short visit and all the reminders they're supposed to check, not to mention the acute issues which the patient came to them, which they actually want to talk about that day. And so I do think health systems writ large really need to do more of what Ralph was saying, really create systems that offload frontline clinicians, either with physician extenders or other ways of using technology to make it easier to both identify people who have health problems or unmet social needs, and then really providing tools to address them, because those tools typically are not in the clinician's toolbox.
Yeah. I want to move on to a question Amit Kara has asked. We've been focusing on identifying the patients with FH who are not diagnosed and figuring that that's a key first step, which it is. But Dr. Kara mentions that you can identify these patients, but frankly, many of us have had the experience, as has he, that sometimes it's just difficult to engage these patients. Just simply reaching out and saying, we think you might have FH. We think that should be a red flag for them, that they automatically say, oh, okay, what do I do next? But it's not always the case. So Dr. Kara would like to know, Kevin, maybe you can start. What are the strategies for just getting people more engaged, beyond just simply telling them you have a condition that is really potentially very bad for your health?
Yeah, well, it's a great question. And a shout out to Dr. Kara. Amit and I were residents together, and I know what an outstanding clinician Amit is. And if he can't convince patients, it highlights that it's really pretty difficult. I think part of the challenge here is coming back to some of the behavioral science obstacles I raised during the talk, is we have a real challenge where you have young patients, asymptomatic, probably feel fine, and then we're saying, you have a serious problem, you need to go on lifelong therapy. It's going to lower your risk of having bad things happen to you in the future. But we know that young people in general, and when I say young people, I mean, we could be talking about people in their 20s, we could be talking about children, and the time horizons are very different than for adults, particularly older adults. You know, if I say, well, this may affect your risk of having a serious medical problem in the next 10 to 20 years, that's an eternity, you know, particularly if you're 9 years old. And so inherently, it's a really challenging problem. I think some of the behavioral science strategies one might think about that might work well in adults probably won't work well in kids. So for example, I mentioned the use of defaults. Defaults are used in a lot of settings like retirement savings, where people probably want to do it anyway and they just don't get around to it. So if you do it for them automatically, they're perfectly fine with that box being checked for them. That's a totally different story if you're talking about my child who's 9 years old and putting them on a medication. Mm-hmm. And so I think it does require a much more intensive discussion, counseling, than the system is typically perhaps set up to provide. This is a situation where we think about sort of this continuum. Parents have to opt in to do this. And I think they're going to need a lot of encouragement. It's not something that you can just sort of automate in any way, shape, or form.
Thanks, Kevin. Mary, you know, this issue of engaging patients, it's one thing when patients sign up to come see us in a lipid clinic, they've already sort of declared themselves as being interested. But this idea of searching the EHR, finding patients, then trying to engage them is challenging. I wonder if you, from your perspective as a clinician and also from your role at the foundation, I wonder if you could just speak to this challenge of patient engagement.
Yeah, thanks, Dan. You know, I think that one of the big issues is a cold call. Patients finding out that, you know, you were identified by this machine learning model, which is excellent at identifying people, and then getting what they view as a cold call. And one of the strategies that we're trying at Dartmouth is having that call come from their trusted physician. So I think that, you know, as Mr. Muller was saying, you know, people trust their physician, they want continuity, and giving the primary care physicians, busy as they are, giving them the opportunity to really engage with that patient and be the one to prescribe the medicines, or just say, you know, we've identified you, you know, you might like to be seen at the lipid clinic. The other thing I would just point out is the children aspect. Kevin, you are 100% correct. When we see kids in the lipid clinic, we know that we need to see them 2 or 3 times before the parents are ready to engage in, yes, okay, my child will take a statin. So it is a process. And I think you have to gain people's trust before they're willing to take the medications.
Catherine, I'd like to maybe ask you to comment on this too, as a patient, and of course, as your perspective and having dealt with lots and lots of patients from the foundation point of view. This issue of patient engagement, and can I just add one other thing onto it, which is there's the engagement of the patient with regard to their own care, but then another thing that we've all struggled with is engaging them in the cascade screening part of it and being a partner and reaching out to not just immediate family, but extended family to try to get, that has been super challenging. And maybe you could just comment on that issue from your point of view.
Well, I'd start by saying that I think most people in the United States do not have a very concrete, can you hear me? Mm-hmm. Okay, great. Do not have a very concrete idea of what heart disease is. I mean, there's a lack of urgency around heart disease in general. And then you add on to that the fact that you have a genetic condition that would make you vulnerable to heart disease decades sooner. And there is a lot to educate an individual on. And what we see is that they need more than the 10 or 20 minutes with their physician. They need to hear it from a variety of voices. They need to read it. They need to join social groups where they hear other patients who look and sound like them, their mothers, or they are someone who just recently had a heart attack and wish that they had listened to their doctors for decades. So I would just add on to what Ralph said, which is I think that the healthcare system needs to set up a structure to support patients along their journey. But where we currently are in the American healthcare system is it is so fragmented that patients, that burden often falls upon them and it is being filled currently by other types of organizations like the FH Foundation. And you know, I see the social pressure, the social accountability that that these Facebook groups put on patients to go ahead and lower their LDL, to persevere and try another statin, or to feel comfortable to try a novel treatment. So I think we have to remember that individuals outside of the healthcare system are also very busy and need continual reminders and support. They need structure, just like physicians need, to make good choices.
Thanks, Catherine. I couldn't agree more. I'd like to go to a question that Vera Bittner posed that I think is absolutely fascinating, and I can't wait to hear what Kevin and Ralph have to say about it. And it has to do with the fact that people are different, and people are undoubtedly going to respond to behavioral economics interventions in different ways. So Kevin, the question is, to paraphrase Vera's question, what is the science behind trying to profile individuals psychologically a bit and tailor the behavioral economic intervention to more of a specific psychological profile, or you know what I'm trying to say. So rather than one size fits all, really trying to get more sophisticated about the interventions that might be employed.
Yeah, no, this is an increasingly hot area of research among social scientists, and people have thought about this as the behavioral analog to precision medicine, and the term behavioral phenotyping is getting bandied about with increasing frequency. So the challenge is that, I guess there are a couple main challenges. One is having a standard validated battery of instruments, which doesn't take a long time for people to fill out, and figuring out when you give this to people and how do you get them to do it. So you need to collect that on a lot of people. There have been some efforts to do that as part of behavioral economic intervention studies, where then people are trying to look at, in essence, what personality characteristics predicted how well an intervention response went. But the problem is these studies, generally speaking, are only powered to look at main effects and not interactions. And so it's sort of exploratory, it's interesting, but not very conclusive. So then you could think, okay, well, what if we pooled lots of studies and they all collected exactly the same information? Then maybe across them, we could say something about how, you know, people who have a bigger focus on immediate gratification respond better to this kind of intervention. And that's one way the field is going. I think another direction the field is going is trying to see, are there ways to capture, again, coming back to the EHR, information that's in the EHR, which may not, there's no personality questionnaires, but maybe there are other observable elements that have some significant and reliably reproducible correlations. And so that's what people are starting to look at, you know, because I think the world in which everyone will be filling out questionnaires repeatedly seems less likely. Like, can we somehow capture, either through EHR, other forms of digital data, information about people that reveals something about their personality that could then be predictive? I think that's where a lot of people are thinking we might be able to move in the direction you're suggesting.
I wonder if
let me add, Dan.
Please, Ralph, please. Yep.
The arguments that have been escalating in the last decade or more for diversity come bear very much on this question. So especially as we think about care teams, doctors, nurses, therapists, counselors, social workers, and increasingly we see patients being seen by care teams, especially in my thesis that we should think about taking care of patients for 10, 20, 30, 40 years rather than just episodically. So when you think about patients over many years, when you think about a care team, you think about a diversity of people, you know, by gender, by ethnicity, by race, having people understand the populations that we serve from a fuller range of life experiences is often a very good way of dealing with the issues that have been raised here. So I applaud the kind of work that Kevin has done on the social science side, but also just how you constitute your care teams to make sure that the array of experiences that patients present beyond their medical can be anticipated. For example, one of the colleagues we all have, Dr. Shreya Kangovi, who's also in the Department of Medicine with Dan and Kevin, has put together about 60, 70, what we call community health workers as a national model. And these people are drawn from the community. It's one place in which we, in fact, we allow nepotism. We want people who are cousins and sisters and brothers of the family members and our employees to be working in those community health workers. And they are able to work with the families on a daily basis over the course of years. So I think the arguments for diversity and inclusion bear a lot of fruit here.
Yeah, thanks, Ralph. Actually, this topic of inter-individual differences, I just want to follow up on that with regard to clinicians and physicians. And at the health system level, whenever you sort of put in something new, some physicians are going to say, oh, great, you automated that statin prescription. That's one less thing I have to do. And others are going to say, I can't believe you would take away my autonomy by automating that. And there's a wide range. And I mean, there's no easy answer to that. But I'm just wondering from your perspective, how you kind of deal with system-wide changes where clinicians are going to vary a lot in terms of their acceptance of those interventions.
Well, that's why we have good leaders like you of departments who are very sensitive to all those nuances. I mean, obviously, one of the real pluses and minuses of the great medical centers, which happen to be represented on this call today, is the kind of collection of great talent who want to be highly autonomous, who kind of come together. So one of the central managerial talents is how do you get the best of their autonomy, yet get them to work as teams. And I think to use the kind of sports analogy, you constantly have to remind them they're a member of a team. And while one can put forth best opinions, not everybody gets a veto on what we do. So we try to form consensus as best we can, put best practice out there, constantly keep reinforcing what best practice looks like, and then show people outcomes. I always try to tell people, if one group has better outcomes, maybe you should pay attention to them. And learn from that, as opposed to thinking the way you're doing it makes sense. So I think the work that's been done the last 15, 20 years, especially with the kind of colleagues that you and Kevin and I have, like David Ash and others, makes an enormous difference in terms of if you have better outcomes, then perhaps you should be listened to, as opposed to just voicing your autonomy. So as I mentioned earlier, bring down the variation in American medicine would be a good thing. It doesn't mean we don't get great individual talents come to these places, but you have to look at outcomes before you get too presumptuous about you always know the best thing.
Great, thanks. One of the comments from Meral K is about group events that can promote doing the right thing. And they mentioned that they bring FH families together for group events that help with adherence and education. Josh, it looks like I got a message, maybe you wanted to answer that, but I just want to say that sort of goes along a little bit with what Catherine was saying about using social media and other ways to connect patients in a way that kind of, not peer pressure, but peer grouping can really help people understand this is the right thing to do and do it. Josh, would you like to comment on that?
I was just saying that I thought that you guys were going to answer it as a panel earlier, but okay. I do think that is something that we need to be exploring, especially in the world of digital medicine and the ability to do meetings like this where we can connect people from all over the world and expand our reach. I think that's for something like FH, that's incredibly powerful. I know that there was a question from one of our former board members, Dave Pickard, who said, there's not enough lipidologists. If we continue to identify all these FH patients, Dan won't be able to see all of them, Mary won't be able to see all of them, but I'm kind of quasi-optimistic that the ability to do virtual medicine might actually improve our ability to reach patients with a genetic hypercholesterolemia.
Yeah.
You know,
Yeah.
I just make one comment too. You know, when the FH Foundation brought together families with HoFH, homozygous familial hypercholesterolemia, it was the first time that many people had ever met somebody that shared that diagnosis. And it was incredibly empowering for those patients.
Yeah. Yeah.
Yeah, I'll also add there's some interesting studies that have been done in behavioral science around peer mentoring, you know, and contexts like diabetes. Somebody with a new diagnosis, somebody who's had the diagnosis for a while can help that patient navigate. That's a really effective way to augment what can happen in the clinical settings.
Right, and very much what the FH Foundation does with pairing people who have had their FH diagnosis for a longer period of time.
Kevin, it's getting away a little bit from FH, but you know, one question came in that I think is very relevant for the next 6+ months, and that is the issue of COVID vaccine and how you're thinking about applying your tools to the really challenging issue of people who are resistant to actually taking the vaccine. I'm just wondering if you could speak to that.
Sure. Well, we actually just wrote a paper on this that's under review and which I'm guardedly optimistic is going to be accepted. And so I think there's you know, some obvious things to do in terms of emphasizing science and having credible experts and really pushing things out on the way you would. I mean, there's a long literature of this because vaccine hesitancy is a much bigger problem than most people realize. So for example, in the context of COVID, we would assume, you know, some people would assume everyone would want the vaccine if it were available tomorrow. And the studies have suggested that maybe 50 to 60% of Americans are likely to say yes, probably or definitely. And that percentage is much lower among groups like African Americans who have been disproportionately hit by COVID. The Pew study that came out in September suggested only 32% of African Americans were likely to say yes to getting vaccinated. And as we know, there's a long history of mistrust of the government and research ethics and so on and so forth, which I think underlie that. So what do we do about that? Well, I think the first thing is to make the vaccine available for free and to make it available easily through a lot of outlets. That's obviously going to be a challenge given some of the distribution issues. Secondly, we can think about ways to, you know, in essence, create incentives for people to use it. And I don't know how far the government would be willing to go along these lines, but if you think about mask wearing as an analog, where if you want to go into a store, you want to get service at a restaurant, you know, whatever it might be, if you want to go to school, you're going to have to show proof you've been vaccinated. And we're used to doing this, of course, with vaccines in schools. But as we know, there's been a major loophole, which is people can request exemptions. And then the question is, you know, if you think about this as an analog to an opt-out default, how easy is it to opt out? And you can really make it very difficult, or you can make it very easy. We can also think about ways to incent, for example, employers to encourage their employees to get vaccinated. Another approach we think could be helpful are what we call credibility enhancing displays. So it's much more powerful for people to actually convince others by showing they themselves are doing it as opposed to telling you to do it. But anyway, there's a whole series of these strategies that could be rolled out. I think we're going to basically need to use all of them because this is going to be both extremely important and extremely difficult.
Thanks, Kevin. We're going to wrap up in the next few minutes, but I did want to ask Ralph a version of a question that came in from Bly Call. And that, Ralph, has to do with the economics from a health system perspective of engaging and investing in prevention, prediction and prevention. It's clearly the right thing to do medically, anticipate who might get sick and do things to try to prevent it, but it's also expensive and not terribly well reimbursed. Could you just speak from your perspective about, you know, the economics of really systematizing prediction and prevention from a health system point of view?
Yeah, and it's a very apt question because unfortunately, the American healthcare system, in addition to science and breakthroughs, there's payment, and they're not always overlapping. So, for example, if you have a population on Medicare over 65, obviously by definition, then Medicare is going to be responsible for that population from then on. So once you're 65, then they have both a patient and a economic interest in continuing to serve you. On the other hand, as Kevin has shown in some of his studies on smoking cessation, especially at GE, if you ask people who are 27 or 30 years old to engage in smoking cessation studies, in due time, GE may say, well, the real exacerbation of their smoking may be when they're 57 or 67 working elsewhere. So why do I want to pay for it for 30 years from 57 to 67? So the question hits that kind of mismatch right on the head. I mean, with FH obviously coming early in life, that is a real challenge because the programs that pay for it, whether it's national insurers like Blue Cross or Aetna, may think that family is going to be living in California 1 year and Philadelphia the next, or insured by Blue Cross 1 year and Aetna the next, they may have some mismatched incentives to take care of them. So this is a real central challenge. So when you have a population that is going to be with you for 10, 20 years, there's a real economic interest in doing the right thing. When that is not the case, we have a lot of fragmentation in America. So that's why I focused earlier on the kind of professional obligation to take care of patients over a period of time, and the extent to which, the kind of part of the good news about more healthcare concentration in America, which I know a lot of economists don't like, is that if the Dartmouths and the Penns and the Stanfords, again, represented on this call, can take responsibility for people for 10, 20, 30 years, that would be a good thing. But as the question indicates, there's still a central challenge here when you're dealing with diseases of childhood in terms of where's the economic incentive to take care of people when the real high expression of the cost, maybe 20, 30 years down the road, is a real central challenge.
Great.
Which is one of the reasons, I mean, I think there's a lot of political issues with Medicare for all, so I'm not going to get into that. But one of the things that Senator Sanders and others, one of the things they were touting in Medicare for all is basically whether you're first diagnosed at 9 or 19 or 29, you're covered for the rest of your life. And that is one of the advantages of it. I don't think it's going anywhere, unfortunately, but that is one of the advantages of it.
Ralph, can I end with a question that relates to what you're currently doing? You're chair of a seminal health fund, an investment fund for healthcare technology, as I understand it. I'm looking for any inside information, but I would be interested in your sort of big picture view on all the technological advancement that's coming along and how you see that impacting on our ability to care for patients from a kind of a technology investment healthcare point of view. If you're comfortable.
Well, I'd be glad to. Even pre-COVID, there's a lot of advances in telemedicine, and I think more and more care is going to be done at the home. So on the one hand, while we still call ourselves hospitals, by and large, we're health systems now. At Penn, I'm proud of the fact we have a major home care operation that spans the geography. And again, to tout the virtue of a common electronic record, when nurses and other caregivers go into a home, they have access to the record. They don't have to start again from scratch. So I think the telemedicine revolution is here to stay. The technology's been there for 10 years, but now there's payment behind it. So I think that will keep accelerating. So one theme I see is more and more care at the home, more and more care in distributed outpatient centers. When you think about, as I saw in the news the last few days, kind of 10 or 20 ICU beds in the whole state of North Dakota, South Dakota. I may have the state wrong, but one of those states like had 10 or 20 ICU beds. Increasing the care is going to be much more distributed, and places like us will be able to reach out through the technology that you referenced earlier. So that's theme number one. Number two, the big corporate entities like Amazon, Apple, and so forth, we may not like them, but they're coming to healthcare in a big way. They're making enormous investments, $1 billion there, $1 billion there, small peanut, it's small money for them. At a time that we have constraints on the federal budget and so forth, and some perhaps gridlock there, depending on what happens in the elections next month or so, there's going to be big money coming from the corporate sector into healthcare, and not just on vaccine development and pharma, but on care delivery as well. So part of what I'm working on is how you reform care delivery. So my themes are much more focus on telemedicine, much more focus on the corporate sector and coming into healthcare, because they figured out that 20% of healthcare, 20% of the national economy in the US is in healthcare. And let me tell you, when you look at Western Europe, Japan, Australia, US, all rich countries spend more money on healthcare, and especially as the population ages. And since the baby boomers are still the first or second biggest age cohort in society, we're going to spend more money on healthcare. It's going to go from 18 to 25% in the next decade. So those themes of more money on healthcare has to be well spent, more big players coming in, more telemedicine, more machine learning, more decision analysis, and all those themes you're going to see happening. So we'll still have hospitals, and we'll still need hospitals to anchor our communities. And I'm proud of what Penn Medicine does, but more and more, the kind of technology, the smartphone, and the kind of learnings that come from the work that you and Kevin have done is going to be increasingly seen as a feature for the populations we serve.
Thanks very much, Ralph. That's great to hear your perspective, and a great place to wrap things up, I think. Just to bring it back to FH for a second, I think a lot of what you've described, Ralph, and the new technologies and new ideas and some of what Kevin talked about, they need to be sort of proven and piloted at one level, often at kind of a health system level, like Kevin described. But then there is this need for generalizability and portability. And with regard to FH, I think one thing we see the foundation playing a key role in is really helping to take that proof of concept in health system X, and then how can we actually take that to other health systems and other practice settings to really generalize it. And I think that's increasingly a role that we see the foundation can really play a tremendous role in that process. So with that, I'd just like to first thank our speaker, Kevin, our panelists very much for what I thought was a really robust and interesting discussion. And I'd like to also remind you that our next summit will focus on Lp(a) and drivers of cardiovascular risk, inherited risk, sorry. And you can see our speakers on this slide, Sam Smeekus, Kathy Thompson, and our own Mary McGowan as panelists. And we're really excited about this topic. I think many of you know that the FH Foundation has taken on responsibility for the familial LPA issues and has its own website related to that. Encourage you to visit that. This session will be held on January 27th. Just to point out, this is a new date from when this was initially announced. It was pushed back due to the inauguration, and we'd like you to make sure you make this change in your calendar. And then finally, we'd really, again, like to thank our 2020 FH Global Summit sponsors for their very generous support of this series. So once again, thank you, Kevin, thank you, Ralph, Mary, Catherine, for your participation in this event today. And everyone have a great day.
Take care.
Thank you, everyone.